uh, bio degree, and then some extra school for dosimetry. So dosimetry is just a big word, but I like to basically um, explain it as pharmacy. So uh, most of us have gone to the doctor for something, some illness, some sickness we've ever had. And you'll get a prescription for a certain amount of pills or injections or whatever for a certain amount of days that total to this total prescription. Same thing with like Advil and Motrin. You take one pill is 200 milligrams, whatever, and you take so many for so many days. So radiation, we give it in the same way. Once a physician has decided that radiation is going to be a part of a treatment plan, then we figure out based on clinical presentation. So um, a lot of breast patients will hear all these terms thrown around. They'll say ER/PR positive, DCIS, or stage two, stage three, lymph nodes, all of those things. That tells us where the tumor is, what the chemical makeup, the biological makeup, what it's going to respond to treatment wise, and what's the best way to attack the situation. So dosimetry is a behind the scenes job. We
Mhm.
are a part of the care team. Most times people are going to see the physician, the resident, the doctor in training, the nurses, the therapist. But there's a whole other group of people in the back who are working on the treatment plan and making sure that the machines are calibrated and the treatment plan is what the doctor has designed for that specific patient. Um, so hopefully that kind of makes sense. Please
Yeah.
feel free to turn off your mute and ask questions. I know a lot of times in those consult rooms, the physicians are saying a whole bunch of stuff and it just kind of flies over really, really fast. So that's kind of dosimetry in a nutshell. We can treat any kind of site, head to toe. Doesn't always have to be cancer. We can treat people have ringing in their ears. That's something that we have done before. Nerve pain, osteoarthritis, keloids. So there are other things outside of just cancer. So anyway, so the first question. So I was looking for a million and one things to do outside of college when high school was ending. I wanted to be marine biology, forensics, med school, vet school. I was looking at so many different things. My parents are both in the medical field. So my dad just kind of started bringing home things that he was hearing about. And he said, "Hey, I've heard, there's dosimetry." And I was like, "I don't know what that is." So he brought home a flyer and we kind of looked into it. And he said, pick one thing, sit down, get the degree for that thing, and then if you end up not
Mhm.
liking it, you can always change. And I've always wanted to do something to help people to give back in a medical space. So I've kind of in, did some internships with people, volunteered at the local hospitals at home, and settled on dosimetry. So I went and got a bio degree and then dosimetry school after that. So it's a lot of physics, math, science, biology, anatomy stuff. And then I did my first job in New York. So I've been in three different hospitals, two different states. I worked at Brookwood for a little while after I moved to Birmingham, and now I'm at UAB. So I've been in this field for about 10 years, seen all kind of patients, treated all kind of things. And that is just a little bit about me and kind of what dosimetry is.
Gotcha. So you did a great job of kind of explaining what a dosimetrist does and just really giving more details about the profession. I know for me, my first time learning about dosimetry was when I got to Forge and just in the world of breast cancer. Um, so I guess my next question would be, could you walk us through your role? So what your role would do upon a person's diagnosis. So basically from like the time that a person is diagnosed and then from the time they're referred to radiation, what happens on the patient side and then what's happening kind of like in the dosimetry space for, because you did say that it's more of a behind the scenes profession. And so for individuals to kind of get a bigger picture of like what's happening with their treatment plans, could you describe like what happens?
Yeah, for sure. Okay, so I'll walk through as if I was patient. So having an issue, go to the doctor, find a lump, whatever it is. The physician says, "Hey, we found something. We're going to do the biopsy. We're going to do the additional imaging." And they say you have such and such breast cancer, right side, T2, T3, whatever. Um, from there, they're going to consult with the team. Based on that diagnosis, they're going to say, okay, this patient needs chemo, or they need surgery, or they need radiation, or they need hormonal therapy, or a combination of all of those. Um, that clinical decision comes from the physician based on what we know about breast cancer right now and what the data says on what's the best way to kind of attack these things. So if you get radiation, we're going to give you a CT scan, and we're going to position you in on the table, make the mold to keep you still. So I need you to be still when we are giving the treatment. So they're going to make a mold, they're going to lay on the table, they're going to do some marking, figure out how to position you, how we want you to lay on the table. And then the physician will probably come in, talk to you a little bit more. Sim will tell you things like, we need you to hold your breath, or you can just breathe normal, or we'll have you put your arms above your head, things like that. And then your scan's going to come to me. So my job at that point, the physician is going to say, "Hey, this is the tumor. This is the area we want to treat." He's going to draw that area. He or she are going to draw that area out on the scan, and then I am going to use a computer system software that's going to take those volumes, and we're going to manipulate the machine. So with that prescription thing, we know from history, from trials, clinical trials, all that stuff, we know that certain tissues can handle certain amount of doses
Mhm,
before something happens.
mhm,
So just like on a TV commercial for like plaque psoriasis, the guy tells you, "Hey, this medicine is going to help your plaque psoriasis," and then he goes a million miles a minute about all the symptoms that you could possibly get and the things that could happen. The same thing applies for radiation. So tissues can handle a certain amount of dose that unhealthy tissue can't. So we give a certain amount of dose to the tumor cells or to the seroma volume, and then we know that it might bother your skin a little bit, but your skin's going to heal. Or we know that we can't give you too much dose before we cause damage to your eyes and things like that. So the doctor is going to go over um, complications, symptoms you're going to see, things that might bother you, with the hope that the tumor shrinks or that we are able to get you to the next step, surgery or whatever. So the doctor draws out all of the margins. The doctor draws out where the tumor is, the things that we need to treat. And then I
mhm,
go into the system and I say, okay, here's the right breast, here's the supraclav, here's the nodes, here's the axillary region. We need to cover all this, but I also need to miss her heart. I need to miss the lungs. I need to miss the spinal cord. So how can I position the machine to treat the unhealthy tissue and spare the normal tissue? So after we make that plan, it's kind of a back and forth between the doctor and I. Um, Best case is that we give as much dose to the tumor as possible and as little bit of dose to the normal tissue. It's a
mhm,
balance. There's not a situation where you can do one or the other. You do end up with hurting the normal tissue a little bit, which is the symptoms they tell you. Your skin's going to get irritated. You might have nausea. Um, you might have weight loss, things like that. Your hair might fall out a little bit. Some of those things are symptoms of the medication, and then some of those things are because of the radiation. Um, but they're going to go over all of that with you depending on where your site is. So once the doctor and I have decided on the best plan, I'll show him the plan I've made. They're going to say yes or no. And then there's another team after me who's going to check
mhm,
it. They're going to check the physics. They're going to make sure the plan makes sense. What the doctor asked for is what we're delivering. They're going to ask, are we on the right machine? Is everything correct from a machine standpoint? And then it's going to go to therapy, and therapy will give the patient a call, and then they'll come in and do the treatments for however many days the doctor has decided. So you can come in for one treatment, you can come in for 4, for 5, for 20. It depends on what the course of treatment is going to be. So that is a clinical decision from the physician, but we get as close as we possibly can with the treatment plan to treat the normal tissue, um, spare the normal tissue, and then shrink the tumor, kill the tumor, and go from there. Does that make sense?
It does. It's so intricate when you think about all that goes into radiation therapy for cancer.
Yeah.
And I know for me, like I said, I had no idea all of this was going on behind the scenes and being considered, which just kind of leads me to my next question. So, are there any like special protocols or precautions the team takes? Let's just say once a little bit of the healthy tissue has been damaged, what additional steps are taken from there? And I guess to I guess like maybe further prevent any more damage. What would that look like?
So there's going to be, and I don't like the word damage, there's going to be a reaction that happens. Your body is going to react to the treatment. Depending on where it is, and how long you're going to be under treatment is going to depend on what the symptoms are. So short-term symptoms, most women experience breast skin irritation. So the skin gets itchy, red, flaky, it's inflamed, it hurts. Um, Other symptoms, sometimes if we're treating on one side or the other, you might get nausea because your bowel and your stomach is in the field because of how far down we have to cover for the breast tissue. So you wouldn't think that, oh, I've been on treatment for 2 weeks. Why am I so nauseous for a breast treatment? But we might have had to cover some tissue down there. So you might get nausea, you might get um, skin irritation, if you're in combination with chemo, then your hair might fall out. All so these things are temporary because once you stop treatment, your skin's gonna heal, your hair will grow back, the nausea will go away. Um,
Mm-hmm.
Other sites, so other treatment sites have some more permanent issues depending on how extreme. So, for example, lung treatments, depending on if the tumor is near the rib cage, we might damage a rib, and they'll tell you that in the consult. It's We have to damage some of the tissue, but
Mm-hmm.
most of it is repairable. It just takes time. So over time, get your skin will go back to normal, your hair will grow back. Um, but we take every precaution. So we have these numbers, we have these constraints before things um, are not irreversible, but before too much damage is done. So for a heart patient, for a breast patient, I am concerned about how much dose your heart is getting. I'm concerned about your lungs, your spinal cord, your esophagus. I'm concerned about um, your thyroid gland. I'm concerned about all of this tissue in this area, your brachial plexus, the nerves that run down your arm. So we have all those numbers, and we make sure that when we're running the algorithm, we put those numbers in the computer so that we're not going beyond the limits, beyond the thresholds of what the trials have told us are acceptable.
Gotcha. And so we kind of touched base on like just some of those common reactions, if you will,
Yeah.
from the radiation treatment. But are there any like specific symptoms that individuals should report to their healthcare providers if they're experiencing them that might be like a red flag?
Um, I will say there there are short-term and long-term reactions that'll happen. I think the biggest thing is that you know your body the best. And
Right.
that's whether it's cancer or the flu or COVID or whatever. You know how your body operates when you feel good and healthy. You know what it feels like when you don't feel right.
Mhm.
And if there's anything that's happening during treatment or after treatment, um, that just doesn't feel like what you normally feel like, it's worth telling your physician because you never know how it's connected. So there are some reactions that happen for different diagnosis that are like if you combine it with chemo, maybe your
Hmm.
skin reaction is way worse than somebody who's not getting chemo. But if you don't say anything because you just think, oh, I'm under breast cancer treatment, then oh, my skin is just gonna whatever. You the doctor can help. There might be a different cream they can tell you about. There might be um, a cold compress. There might be something you can do that would alleviate some of your issues. So I would say some of the short term things are like skin changes. Um, your breast can kind of feel like extra heavy or swollen or tender. Um, Fatigue is actually pretty significant. I know a lot of people don't think fatigue is a big deal if you're not getting chemo, but anytime your body is fighting a disease, you're tired. You are not at your full capacity. So extreme fatigue or just kind of not feeling like yourself is totally normal. Um, Fibrosis and like scar tissue is kind of more of a long-term thing, depending on how much dose you get, or where the if there's a scar, if there was surgery, that might be a little bit more permanent. Um, but the trade-off is that the tumor is now gone. So women will have fibrosis scars or some extra scar tissue from surgery or from radiation. Um,
Hmm.
Lymphedema is kind of something that women struggle with. So your lymph nodes in the area get a little overreactive and they kind of swell. And I know that some patients will have sleeves that they can wear or they'll do
Yeah.
physical therapy. So lymphedema, if your arm starts to swell and it's uncomfortable, let your physician know. Um, Skin changes, fibrosis, and then anything random. So trouble breathing, your lungs might have gotten affected. That's worth talking about. And I think nausea is probably the one that nausea and then throat irritation. So if we have to treat not just your breast tissue, but sometimes they'll say nodal, so supraclav nodes, there's a nodal chain in between your neck and your breast tissue that goes out to your arm. So if we have to treat it in this area, then sometimes we might have to cover medial and then we'll hit your esophagus. So your throat might be a little sore, might be a little painful. So anything that is uncomfortable is worth talking about. And even if it sounds silly, it's better to have brought it up and let the physician know so that it's on the record. And they can tell you, oh, that's normal. Oh, we can give you a pill for that. We can give you a cream for that, or we can have you see somebody, or we can dig a little bit farther into it and see, am I covering too much of her esophagus? Do I need to put in a block on the machine? Do I need to do something in the treatment plan that'll help block out more of her stomach or something like that? So um, no symptom is worth suffering with without saying anything to anyone.
I like the way you put that. And I agree, and with everything that we discuss as well for all the individuals that are on now, if you have like any questions about anything that you want to direct specifically to Christine, we'd be happy to um, or I'd be happy to get like your contact information. I can send like some more personalized questions to Christine if you
Sure.
have them. Um, but I love that ending statement. I guess my next question would be, are there any factors that you all consider when designing a treatment plan for someone with breast cancer? We kind of touched on it a little bit earlier, but um, I know like location, the tumor size, all of those are different factors that go into it. But are there some things that people may not be aware of that might go into designing a treatment plan for someone with breast cancer?
Um, so age, we consider age when we're considering constraints that we're worried about. We
Hmm.
consider transportation. We consider where you live. It's unreasonable in this day and age. So radiation is changing rapidly. Healthcare is changing rapidly. A long time ago, a radiation plan would be 25 fractions. That means you have to come to the doctor every day for 25 days, Monday to Friday, to get your treatment. That would take you like 2 months. We
Hmm.
are moving into the space where we can give the same effective treatment over a shorter course. So instead of coming for 25 days, maybe you come for 16, maybe you come for 5. So we have patients at UAB that live really far away. They can't get here. They don't have reliable transportation. They're not going to make 25 fractions. So instead of them not getting treatment at all, we can change the dose, we can change the fractionation. So we consider where you live, we consider how old you are, we consider do you have other comorbidities? Do you already have a history of something else in your family?
Mhm.
Do you have you already had breast cancer before? Do you have any other kind of cancers? Do you, if we're on the left side versus the right side, we're a little bit more picky about our heart dose because we're closer based on how the chest anatomy is. So maybe we are more concerned about a ventricle if the patient has heart problems. We consider pacemakers. So if you have a pacemaker, if you have hardware, if you have screws in your back or anything like that, all of that stuff is something we write down and we look at. So pacemaker patients, we have special doses for them because we don't want to ruin their hardware. Um,
Mhm.
we consider, trying to think of what else. Anything, yeah, anything like that goes in the chart during consult time. Or
Mhm.
SIM is also going to ask a bunch of questions when you come in um, that we record. So
Gotcha.
I think people don't think transportation is a big deal, but transportation is a big deal. So I've had
Yes.
patients where they tried to come for a couple fractions, couldn't finish, um, and then we either had to restart over or stuff like that. So we consider full picture, which is why the interdisciplinary part is really important. So um, it's not just the radiation oncologist that you've seen. They've talked to chemo, they've talked to surgery, they've talked to physics. If it's something complicated, they've talked to me. They've called me and said, "Hey, I've got this patient. We're worried about this. We can't get her arm to move." A lot of times after surgery, um, that's a big deal actually. A lot of times after surgery, your shoulder is really stiff and it's hard to put
Mhm.
your arm up in this position for breast cancer treatment. So those are things that we consider. Um, so yeah, we consider a lot.
Wow. And I will say, that access to care, that is a huge deal. And I just want to remind everyone who's on today and anyone who's watching the recording, if you are in the state of Alabama or Mississippi, please reach out to Forge. If you're a breast cancer patient, current breast cancer patient, please reach out to Forge because those are the things that we assist with getting individuals to treatment. And it's just to ensure that individuals have, quality of life, as they're going through treatment and they're able to keep up with them. But, in a state like Alabama, where a lot of the state is rural, you're so right about that. A lot of people aren't able to make their schedules as needed,
Yeah,
but it is interesting to to know just how much is considered with individuals radiation plans.
yep.
So this would be my last question, and well, actually, let me see. Okay, well, I have technically two more questions, but so my next question is, what advice would you give to someone who's about to start radiation?
Mm. I would say it is completely normal to be nervous. It's completely normal to not understand what the doctors are talking about. Um, it's completely normal to be concerned. Um, don't feel like you can't ask questions. Don't feel like you can't bring things up, even if it's not your day to see the doctor. So we have these things called OTV days, so on treatment visits. So normally, if you're on, you do your consult, you do your sim, you come back, you start your therapy, and then depending on how long your course is, you'll see the doctor once a week, whether it's in person or virtual. And they'll just talk about how the treatment's going. They'll say, "Hey, you're on fraction 3 out of 20. How do you feel? What's happening?" That's the time to speak up. So even if it's not your on treatment day, grab the therapist when you're getting off the table and say, "Hey, my stomach is killing me. The medicine that he gave me is not working. Can we talk about it?" And the therapist will let the physician know. They'll let nursing know. Everybody on the team talks to each other. So if you have an issue, therapy is going to tell somebody else. Or if you tell nursing, um, somebody's going to tell somebody else to get it where it needs to go. So speak up, say what it is. Even if you have questions, what is this machine doing? What's happening? There's no dumb question. I know that a lot of times there's a lot of terminology thrown around that makes no sense to people who are not in this field. Half of the time, I have to go Google something that somebody has said because I'm like, yeah, that's new to me. I don't know what that is. So don't feel bad if you are sitting there and they're telling you these words that you don't understand. Ask questions. It is your care. They are there for you. So I would say be curious, ask questions. If something is bothering you, let them know. Um, and know that as many precautions as possible have been taken. So we've thought about these things a lot. We have gone over your treatment plan several times before it's gotten to the table. We are human, so we have multiple checks in place before it gets to a patient. Um, but we have thought about things at several steps before it's gotten to a patient. But that doesn't mean you can't ask.
All right. And is there anything that we did not cover today that you think would be beneficial for listeners to know?
Hmm. Um,
Or caregivers?
mm, you know, I don't know. I think you asked really good questions.
Alrighty. I think this was a really reassuring conversation. Granted, I am not doing radiation, but if I were, I think this would bring me a lot of comfort in knowing just how intricate everything is
Yeah,
and the multiple checks and balances too, because I think that's one part specifically that people do have questions about, and maybe they don't know how to ask those questions or like know when to bring it up. Like, okay, well, how do I know this plan is
yeah,
either I'm you can't see me, but I'm doing air quotations, going to work. I hear that phrase a lot. How do I
yeah,
know this is going to work? But it's really reassuring to know that the healthcare professionals, dosimetrists, and oncologists, the whole team, they really go in depth about treatment plans and each person's individual anatomy and any factor that could hinder people from continuing their fractions and schedules.
yeah.
So at this time, I'm going to go ahead and end the recording so that we can open the mic to our live participants. Give me 1 second.